Welcome, brothers and sisters, to your wellspring of knowledge. Remember that knowledge never be toxic to brain, but public serving and saving oriented. Let medicine and health be globally accessible. Hello, friends. I am by the names of Joseph Ndaishimiye. Today's topic is spinal anesthesia. How can you give the patient who is undergoing surgery spinal anesthesia? Let us go on. Friends, first you have to know what's the spinal anesthesia. We have many techniques that you can use to give the patient anesthesia, but friends, you have to know what is spinal anesthesia. As you see, spinal anesthesia refers to intrathecal injection of small amounts of local anesthetic into cerebral spinal fluid. That's one. You can also define it as a lesional anesthesia, which is achieved by temporary interruption of impulsive transmission by spinal nerves after injection of local anesthetic in subarachnoid space. Spinal anesthesia is one of the most commonly used anesthesia technique for lower abdominal and lower limb surgeries due to its advantages. Most common advantages of spinal anesthesia. One is the use of less medications compared to general anesthesia. Second, the patient is cooperative, to mean that for any change, he can tell you. But once you give general anesthesia to patients, he's unconscious, relaxed sometime. He cannot cooperate with you during surgery. Third, friends, you have to know that with the spinal anesthesia, we have less fetal depression. Fourth, we have prolonged block, 2 to 4 hours, which can give postoperative pain relief. We have also patient satisfaction when spinal anesthesia is done skill-free. Spinal anesthesia is also the best alternative to general anesthesia in higher risk patients, such as difficult airway, when you cannot use airway to give anesthesia to patient. Second, those patients with respiratory diseases such as asthma, COPD, emphysema. It's also the best choice in elderly patients, and it's associated with less blood loss. Diabetic patients, this is the best technique, and it does want muscle relaxation because it provides best muscle relaxation for long period of time. Friends, this is the anatomy of spinal cord. Spinal cord, it's a column of nerve tissue that's connected to brain and lies within a vertebral canal from which the spinal nerves originate or emerge. The spinal cord holds 31 pairs of spinal nerves originating from different levels of spinal cord, like cervical level, thoracic lesion, lumbar lesion, sacral and coccygeal lesion. Spinal cord and the brain constitute central nervous system. Spinal cord consists of nerve fibers that transmit impulses to and from brain. Like the brain, spinal cord is covered with three connective tissue envelopes known as meninges, dura, arachnoid, and pia mater. The space between outer and middle envelope is filled with CSF, cerebrospinal fluid. The clear colorless fluid that cushions spinal cord against jarring shock. This is where spinal cord ends in the adult. This is where spinal cord ends in the infant. This is for child. This is the subarachnoid space. This is phylum terminal. This is sacrohiatus. Friends, as we have seen, spinal cord extends from foramen magnum at the lesional cord or base to lower border of L1 or L2 in adult, but L3 in infants and children. It is about 45 centimeter long in length. Spinal cord, as you have seen, it gives 31 pairs of spinal nerves. Dura mater, subdura space in subarachnoid space, and in S1, S2 in the adults, but S3 in the children. An extension of pia mater, which is the phylum terminal, penetrates the dura and attached terminal end of spinal cord, which is conus medullaris to periosteum of coccyx. This is subarachnoid space. It is the space that lies between arachnoid mater and pia mater. It contains cerebrospinal fluid, nerve roots, blood vessels that supply spinal cord. The spinal subarachnoid space extends from foramen magnum to S2 in adults and S3 in children. Let us go on with dermatomes. Dermatome for C8, it's a little finger. T1, T2, it's an aspect of the arm here. T4, it's nipple line or the root of scapula. T7, it's the inferior border of scapula or tip of xiphoid. T10, of course, it's the umbilicus. L2 to L3, it's the anterior thigh. S1, it's the heel of the foot. This is the surface anatomy of spinal cord. C7 is the vertebral prominence here. T7, it's the inferior angle of scapula here. L4, it's the superior aspect of iliac crest, which is Tuffier line. S2, it is the posterior superior iliac spine. Here above, it's sacrohiatus, which is the groove or depression just above, or between the gluteal clefts or above coccyx. Friends, this is the topographic image of Tuffian's line. What's Tuffian's line? Always before spinal anesthesia, palpate. You see people saying that palpate Tuffian's line, so to give to get CSF. What's Tuffian's line? Tuffian's line, it's a transverse line connecting the tops of the iliac crest. It is generally known that this Tuffian's line is a transverse line connecting the tops of iliac crest. It's known that Tuffian's line interact and intersect here at the lumbar vertebrae spinous process, or at L45 interspace. In the upright position, it passes over spine of L4 vertebrae, but it's a little bit changed when the patient's in the lateral decubitus position. It passes over L4 to 5 interspace. The physiology of spinal anesthesia the mechanism of spinal anesthesia means the blockade of nerve roots around spinal cord, autonomic, sensory, motor, and proprioception fibers. Sympathetic block or autonomic. Of course, in autonomic, we have sympathetic and parasympathetic, but here during spinal anesthesia, we more block sympathetic because parasympathetic is craniosacral. So during spinal anesthesia, we block mainly sympathetic because it's thoracolumbar, It cuts off the caliber of blood vessels, heart rate, and GIT contraction. Second, we block sensory fibers and then interact the transmission of sensation such as touch, pain to spinal cord, and from there to brain. Third, we block motor blockade, which cause muscle paralysis. Lastly, we block proprioception, which cause the inability to sense stimuli arising within the body regarding position, motion, and equilibrium. To mean that even if the person is blindfolded, he or she knows through perception if the arm is above the head or hanging by the side of the body. But once blocked, those proprioception is blocked. Friends, those fibers are not blocked at the same time because they are not the same in size. Second, they are not all myelinated. But you have to keep in mind that small myelinated fibers are first blocked, but larger unmyelinated fibers are last blocked. So the first blocked is sympathetic block, and two dermatomes higher than sensory block. You can check this by using ice. Yes, you can use ice or cold swab and then check where the block is, sympathetic block is. Sensory block is two dermatomes less than sympathetic block. Here we can check it. We can check it by saying on temperature or pain. Motor block is two dermatomes lower than sensory block, and then proprioception is the last, as I have said. Now, friends, for which patient is the best choice to use spinal anesthesia? First, all operation below umbilicus. For example, hernia repairs, cesarean section, pelvis, genitals, and perineal surgery, and most urological procedures. You can use spinal for analgesic purpose. For example, you can give opioids intrathecally to alleviate the pain on the lower parts of the body. Last, all the patients with systemic diseases such as chronic respiratory disease, hepatic, renal, and endocrine disorders such as diabetes better use spinal anesthesia. What are the contraindications for using spinal anesthesia? We have absolute contraindication and relative. This is the best mnemonic for you to not forget anything about absolute contraindication. We have a patient with a severe systemic sepsis. Infection control is imminent. First is allergy to local anesthetic. Second, patient refusal. Third, severe aortic stenosis, severe mitral stenosis, infection on the site of injection, coagulopathy or bleeding, diathesis or anticoagulation, because once you inject the spinal needle to the patient with coagulopathy or bleeding diathesis, please, you are going to damage bridging veins there in the subarachnoid space, and then cause subarachnoid hematoma. Please don't use spinal anesthesia technique for patients who are on anticoagulants, and not allowed to give anesthesia via spine to the patient with intracranial pressure, because the brain can immediately herniate into spinal canal. There's a mnemonic for relative contraindication. Here you can judge what to do. The mnemonic is uncontrolled sepsis promotes seizures and hematuria. First, U is an cooperative patient. Second, patient with sepsis. Third, pre-existing neurological deficits. Fourth, spinal deformity. Last, you have heart valvular lesions, which are not severe. Yes, now, friends, how many layers do we pass from outside to subarachnoid space to get CSF? Mnemonic is 3 cylinders. First S is skin, second is subcutaneous tissue, third is supraspinous ligament, I represents interspinous ligament, L represents ligamentum flavum, E represents epidural space where we take our destiny during epidural anesthesia. D is dura mater, A is arachnoid mater. Last, S is subarachnoid state, which is the destiny for spinal anesthesia subarachnoid block. This is the arrangement from posterior to anterior. But in between, remember we have uh, posterior ligaments. And if you advance, you will reach, if you advance beyond subarachnoid, you will reach anterior ligaments. These are the spinal nerves and the blockage effects. Once you block, you give anesthesia and then block up to T1 to T4. You are blocking cardioaccelerator nerves and then parasympathetic upsurges. And then you will have high action of acetylcholine and then bradycardia and the decreased contractility. Vasomotor fibers from T5 to L1. This is for vasodilation. Vasodilation, and then you will have hypertension. Once there's vasomotor, those vasomotors are blocked. This on the level of blood vessels. Once you are at that level also, sympathetic outflow is also blocked. Remember, it's the thoracolumbar from T5 to L1. You will have high, you will block vagoton, parasympathetic. It will be blocked. And then small contacted jet with active peristalsis will be blocked. And then the patient is more exposed to constipation. Most dependent part in the spinal position is between T4 to T8. It's more important for hyperbaric solution. These are the most important factors affecting spinal anesthesia block or subarachnoid block. First one is the varicity of anesthetic solution you are using. If it is hyperbaric, hypo or isobaric solution. Second, there is position. In which position is your patient during injection or immediately after injection. Third, we have the dose of medication injected in the subarachnoid space. Second, the concentrations of your volume of anesthetic or the addition of opioids. You know, opioids strengthen and prolong the block. And then since the site of which site of injection, at which level of spinal cord have you injected your local anesthetics or opioids. Others which are not matters much in pregnancy and intra-abdominal pressure, curvature of spine, drag volume, needle direction, patient height and age. Friends, we have talked many things on spinal anesthesia, but all we do is use spinal needle. Spinal needle. We have mainly Whittaker needle, Quenk needle, and spirorate needle. This is Quenk, this is Whittaker, this is spheroid here. Friends, all spinal needles should have a tightly fitting removable stylet that completely occlude the lumen to avoid tracking epithelial cells into subarachnoid space. On the Quenk needle, you have to know that it's a dura cutting sharp typing needle that is considered to be the standard spinal needle. Second, we have a Whittaker needle. It's the blunt, dura separating, non-cutting pencil point-like needle that separates fibers. This has evidenced to have low incidence of post-dural puncture headache (PDPH). Third, this is pilot needle. It's the side injection, with long opening. Pilot is of advantage because of more vigorous CSF cerebrospinal compared with similar gauge needles. Friends, thank you for taking your time on this channel. I really know that you have unleashed, you have revised many things you haven't known on this